Hi, my name is Dr. Warren Fingroot, and I'm a hematologist and a fellow with the Adult Bone Marrow Transplant Program with Memorial Sloan Kettering Cancer Center in New York. And I'm also director of Stem Cell Club, a nonprofit organization based in Canada that works to recruit Canadians as potential stem cell donors. My talk is titled Addressing Racial Disparity in Blood, Stem Cell, and Organ and Tissue Donor Pools. And this is a talk for the Donor Research Network Symposium Series. So this talk will outline racial disparity in donor pools for first blood donation, red cells and platelets specifically, then blood stem cells, specifically adult donors and cord blood, and then organs and tissues. And it will review the etiologies of these disparities as well as some potential solutions. First, I'll define my terms. So I get my definitions for race, ethnicity, and ancestry from this recent New England Journal article on time for reckoning with racism, race and genetic ancestry in medicine. I define race here as one's identification with the group identity ascribed on the basis of physical characteristics and skin color. Ethnicity, as in Hispanic and Latino, captures common values, cultural norms, and behaviors of people who are linked by a shared culture and language. And ancestry captures the genetic origins of a population. So although race and ethnicity correlate with genetic ancestry, they each capture different information. Race and ethnicity are self or socially ascribed, whereas ancestry better predicts inheritance of certain genetic variants. I'll start talking about blood, red cells in particular. So on blood cells, there are these major blood groups, these antigens that are found on the surface of red blood cells. And you can see that in the figure on the top right, A, B, AB, and then if you're type O, you don't have those antigens at all, actually. And standard of care is to provide patients who need blood with blood that's compatible with their ABO blood group and also that's matched for one of the minor antigens called RHD, where possible. And that's especially true for premenopausal women, where it's a priority to match RHD for those women. However, there are many other minor antigens that are found on the surface of red blood cells and against which a patient can be alloimmunized, i.e., clinically significant antibodies can be formed after a blood transfusion if the patient doesn't already have those antigens on their blood. You can see a bunch of minor blood antigens in this diagram on the bottom right. For patients with sickle cell disease, for example, who receive blood transfusions, the American Society of Hematology guidelines recommend that prophylactic red cell antigen matching for a variety of minor antigens at Rh and as well at Kel is important above and beyond the standard of care for all other patients, which is ABO and RHD matching. And as well, for patients who have a history of transfusion reactions, matching at other minor antigens may also be warranted. For individuals with hemoglobin disorders, such as sickle cell disease or thalassemia, these patients often need regular blood transfusions chronically or sometimes intermittently. And if they're exposed to donor blood that's unmatched for minor antigens, they're at risk for alloimmunization, that they can develop antibodies to the red blood cell antigens that are foreign. And when a patient's immune system is exposed to an antigen on blood that it hasn't seen before, it can generate those antibodies, and those antibodies can cause problems, including transfusion reactions, problems related to pregnancy, and it's a problem. And so then the question you might wonder is, why do we need a diverse blood supply? What does a diverse blood supply have to do with this problem? Well, blood is more likely to be a close match to the recipient if it comes from a donor from a similar ancestral background. And the example I give here is with respect to two minor antigens, Rh and Duffy, where when you zoom in on Black peoples, that is people specifically with African ancestry or origins, they have Rh variants resulting in partial antigens. 10% of those people have Rh variants resulting in partial antigens. And 68% have no Duffy expression on their red blood cells. That's another minor antigen. But both of those situations are rare to occur in white populations of European ancestry. And similarly, many diseases, many diseases that are treated with blood transfusions, including sickle cell disease and thalassemia, disproportionately affect specific ethnic populations or ancestral groups. For example, in the United States, the prevalence of sickle cell disease is 1 of every 500 Black people, 1 of every 36,000 Hispanic people, and only 1 in every 100,000 white people. And with respect to thalassemia, that's a disease that's prevalent in populations with Mediterranean, Middle Eastern, Indian, Southeast Asia, and Chinese heritage. And if you're looking for a particular blood type, and in the example on this slide, supposing you're looking for blood for a patient that's type O, capital C negative, capital E negative, capital K negative, and JKB negative, If we were to screen, and this is data from the American Red Cross, if we were to screen blood from 250 white donors, we would find that only 1 of 250 units would match this profile. However, if we were to screen blood from 250 black donors, 28 of 250 units would match this profile. What about platelets? Sometimes patients with low platelets or thrombocytopenia can be refractory to platelets refractory to platelet transfusion due to prior alloimmunization against human leukocyte antigens. Those are proteins that are found on the surface of platelets. These patients may need HLA-matched platelets, that is, platelets obtained from a donor that is HLA-matched to the patient. And patients are more likely to find an HLA-matched donor from within their own ancestral group. But for patients from ancestral groups that are not well represented as blood and platelet donors, it will be harder to find an HLA-matched platelet donor for them. Furthermore, most blood donors in Western countries are white. And so you can see here in the diagram on the left, this is data from 2017 from Canadian Blood Services showing the ethnic breakdown of blood donors in Canada. You can see that the majority of blood donors are white, and that's way more than the proportion of white people in the makeup of Canada. And on the right, you can see data with respect to the United States, the proportion of the Red Cross donor pool that's made up of or consisting of African-American donors. And you can see that it's much less than the 13% of the population of the United States that's African-Americans. It's less than 3.5% of donors that are African-American. And that was worsened by the COVID-19 pandemic, where it went down to as low as 2% of the donor pool. Compounding this problem is donor eligibility criteria, which disproportionately exclude specific racialized or ethnic groups from donating. And I give the example here that most blood operators, including Canadian Blood Services, temporarily defer donors who have recently visited countries with malaria risk, and that includes many African and Asian countries. And those are donors that are in particular needed to help serve patients from diverse backgrounds as well. And as well, until 2016, Canadian Blood Services deferred donors from multiple African countries due to the risk of a particular strain of HIV2, that was not detected through standard testing. And in 2016, the testing was advanced such that people from those countries were allowed to donate blood. And similarly, in 2018, due to changing HIV2 risk, 2 additional African countries, people from those countries were permitted to donate in Canada. But these are policies where patient safety was being prioritized over health equity, and both need to be priorities. This is a summary of a systematic review by Spratling and Lawrence from 2019, looking at barriers and facilitators of blood donation in racialized and ethnic populations. And these authors scanned the literature and found that knowing the blood recipient facilitated donation for minority peoples, identifying with culture, race, ethnicity, and religious affiliation facilitated donation. In particular, they give examples where there was a study of Australian sub-Saharan African-American migrants, and they needed to obtain family approval as part of their culture. In Canada, Black participants felt more comfortable donating to someone in their community or in honor of their community. There was a culturally tailored intervention that the authors found promoting minority blood donations, where participants felt guilty for not donating after the intervention, and identifying with ethnicity and religion provided reasons to donate blood. However, medical mistrust and misunderstanding were both barriers to donation. And this, the authors noted, were lingering effects from medical experimentation that exploited minority peoples, including the Tuskegee syphilis study, as well as exclusion of donors from racialized communities and populations during the HIV/AIDS epidemic back in the 1980s and on. And there's a belief among Black participants that was noted, including that their blood was unwanted, that they were ineligible to donate, or that their blood would be discarded following donation. And relatively little research has been conducted to date on how to mitigate these barriers. An even more recent systematic review, an even more recent study by several co-authors that are in the Donor Research Network. In Australia, they performed qualitative interviews with 44 participants from ethnic minority groups, and they found a number of motivations and facilitators to donate, including the desire to help others, connections to the medical field, donating with others, seeing a mobile donation unit. But there were a number of other barriers to donation that were identified as well. And I listed a number of example quotations. For example, with respect to donation convenience, quotation from an Southeast Asian donor that says, quote, we Vietnamese work a lot, and so they are living life and they don't have free time for them to think about stuff like donation. With respect to fear and confidence, this is a quote from another Southeast Asian donor. Quote, my Indonesian friend told me Are you sure that it's a fresh needle? What about if they have used it for other people? They have not thought about that kind of thing. There's that risk of sort of getting illnesses or anything because they're worried the needle's not fresh. There are knowledge gaps that were identified. Similarly, quote, when I was living in Africa, I never thought of it. I never really crossed my mind. It's more of not knowing how many people you can actually help. With respect to language barriers, a participant from East or Southeast Asian descent noted that questionnaires for blood donation should be multi-language, that there are Chinese people living here that don't understand English and they won't be able to fill out the questionnaire. And also privacy for female donors was noted to be a potential barrier with this Melanesian-Polynesian lapsed donor sharing the perspective that a lot of female islanders may be a little put off by being in a communal room where you all sort of sit there and donate blood. They want to be in their own sort of space. They might be a little bit embarrassed about just being out there in the open. I'm going to switch gears now and talk about blood stem cells, adult donors and cord blood. And I'll start by introducing that allogeneic stem cell transplantation is a curative therapy for patients with a range of blood diseases, leukemia, lymphoma, or other immune or metabolic diseases, but a suitable donor is needed. And the first choice donor is a fully matched or HLA matched, human leukocyte antigen matched sibling donor. But the majority of patients, over 75% of patients actually lack an HLA matched sibling donor and rely on alternative donors, which include fully matched unrelated donors, cord blood donors, haploidentical or half-matched related donors, and mismatched unrelated donors. So I'll go through these one by one. So first, an unrelated stem cell donor is one which is accessed via the global network of stem cell registries, which include Canadian Blood Services Stem Cell Registry in Canada, Be the Match in the United States, Anthony Nolan in the United Kingdom. And there are over 38 million donors listed worldwide. And people sign up as donors at their local registry or via their local registry by providing informed consent and a cheek swab generally, or a blood sample for HLA typing. And if a donor matches to a patient in need, that donor will be worked up by the transplant team. And there are two ways they may be asked to donate. And the first way is, and the most common way actually, by far, is donation from blood, where they get a growth factor that moves their stem cells from their bone marrow into their bloodstream. And then blood is collected via apheresis. That's very similar to how platelets are donated. And then you can see that in the diagram on the top right. On the bottom right, you can see an example of stem cell donation from bone marrow. That's done less than 10% of the time under general anesthesia. And these are diagrams that actually Stem Cell Club and I developed, and this is published in Vox Sanguinis in 2020. Now, patients are more likely to find a fully matched unrelated donor from within their own ancestral group due to similar genetic heritage. But patients from non-European ancestral groups face markedly decreased likelihood of identifying a fully matched unrelated donor. And you can see in the graph on the right data from Sloan Kettering, which is the center that I work, showing that both people from Southern European ancestries and from non-European ancestries have a less than 50% likelihood of securing an A-to-A unrelated donor, and this isn't improving over time. And a landmark study from Graggart et al. From New England Journal of Medicine in 2014 found similar results, where Black patients had as low as a 16% chance of finding a fully matched unrelated donor, compared to an over 75% chance for patients of Northwest European ancestry. And there are a number of factors that contribute to this disparity. So first of all, people from diverse ancestral groups are less well represented on registries in the world. So for example, on the top right, you can see data from the Canadian Blood Services Stem Cell Registry, where the majority of listed stem cell donors are white, are of European ancestry. And the other diverse groups are not represented even in proportion to the makeup of Canada. And that's similar data will be true in the United States, in the United Kingdom, and so on. But furthermore, most of the donor registries in the world, and particularly the largest ones in the world, are in Western countries with predominantly European populations. And you can compare that to Africa and Asia, which have a large population bases and very few registries with very few donors on those registries by comparison. And so there's a numbers problem from that perspective. But also, even if the numbers were more equal, certain populations have differences in genetic diversity compared to other populations. And so this figure on the bottom right is from a landmark study from 1995 from Beatty et al., which showed that for adding the same number of donors from one population compared to another population, the proportion that have new HLA haplotypes is higher if you add African-American donors compared to if you add white donors, because the African-American peoples, or the population here, there's more genetic diversity with respect to HLA than the white peoples. Compounding this problem is that multiple studies have shown that when patients from ethnic, racial, minority groups are asked to donate, they have a higher attrition rate. That is, they're less likely to go through with donation if asked compared to people of European ancestry. And that may be a result of multiple factors, including socioeconomic barriers to donation, which disproportionately impact racialized and specific ethnic populations as well. So what happens if a patient lacks a fully matched donor? Fully matched unrelated donor? Well, options include cord blood transplantation, where a cord blood graft is collected from baby's umbilical cord at time of delivery and then stored in the public cord blood bank, where it can be accessed if needed. And cord blood stem cells do not need to be fully matched to the patient. And the aim here is for at least a 4/8 HLA match and for a CD34 dose, where the number of stem cells in the cord blood unit that are CD34 positive, that's important for engraftment. And another option is haploidentical transplantation, where a haploidentical related family member, for example, a child or a parent or a half-matched sibling, can be the donor. And by definition, parents and children are a 50% match, and siblings have a 1 in 2 chance of being haploidentical to each other, 1 in 4 chance of being a full match, and a 1 in 4 chance of not matching at all to each other. Multiple studies have shown that survival is similar after both cord blood and haploidentical donor transplants. And so I shared the data on the bottom left from Sloan Kettering. It's a 90-patient cohort, recent cohort published in Bullet Advances in 2020. And you can see that overall survival at 3 years is 82%, disease-free survival is 76%. Those are outcomes that rival any other kind of transplant. And on the bottom right, you can see data from Rashidi et al. From Bullet Advances comparing matched sibling donors with haploidentical donors. And again, you can see overlapping survival curves and other outcomes as well, with no significant differences. Mismatched unrelated donors are also now emerging as an option for patients that lack any other kind of donor, or who, and it's emerging as an alternative donor option. And here's data from a phase 2 study of mismatched unrelated donors. That is donors that were matched at 4 to 7 of 8 HLA loci, with receiving graft versus host disease prophylaxis with post-transplant cyclophosphamide, sirolimus, and mycophenolate mofetil, or MMF. The study included 80 patients, of whom almost half were from non-white ethnic groups. And the primary endpoint of the study was met with 1-year overall survival of 76%. The study is ongoing. However, despite all these alternative donor options, some patients are without cord blood and unrelated donor grafts. So for example, this is data from Sloan Kettering again, where of patients who were without a fully matched unrelated donor, or a 7 of 8 unrelated donor, or a cord blood graft, majority were African in ancestry. And you can see here that there are patients that lack certain kinds of grafts, and disproportionately non-Europeans. But also, for those who do have a graft, their grafts may not be equal. So here's a study, again from Sloan Kettering, showing that cord blood transplantation extends access, but Europeans have better grafts than non-Europeans, where in this 544 unit analysis for 144 racially diverse adults, you can see that on the left, Europeans had a higher CD34 cell count per graft than non-Europeans. And on the right, you can see that the Europeans had a higher degree of HLA match compared to the non-Europeans. With respect to haploidentical donors, again from our center, data showing that in a study of 89 patients who we looked to see, did they have both a cord blood and haploidentical donor, for non-European patients, a greater number of haploidentical donors were required to be evaluated per patient to secure a suitable graft, and the majority of African patients did not have a suitable haploidentical donor. Most recently, I and together with my mentor, Dr. Barker, we looked at disparities in access to optimal alternative donor allografts of each type. And so in this 592 patient analysis, we examined within each type of donor that was received, did the recipient, receive a quote unquote optimal donor of each type, which we defined as a fully matched or 8 of 8 unrelated donor that was less than or equal to 35 years of age, a double cord blood graft where there was a CD34 dose of at least 1.5 times 10 to the 5 per kilogram per unit, as well as a 4 of 8 HLA match per unit, a haploidentical donor that was 40 years of age or younger, or a mismatched unrelated donor that was 35 years of age or younger. And you can see that in this graph over here, the Europeans were more likely than non-Europeans to have an optimal donor over time, with non-Europeans having a 67% chance of receiving an optimal donor versus an 84% chance for Europeans. And data on the right, you can see for the 8 of 8 unrelated donors in particular, showing that the unrelated donors were older for the non-Europeans compared to the Europeans. And the takeaway point from this is that in the era of donors for all, there's a need to recognize that there remains disparities within each donor type, and that there's a need to recognize in our field optimal donor definitions as well. Next, I'll talk about disparities in organ and tissue donation with a focus on kidney donation. And I'll focus specifically on these two systematic reviews of the literature, scoping reviews by L. Dasuki and Muxie and colleagues, looking first at the Indigenous communities of Canada, and then at East Asian, South Asian, and African, Caribbean, and Black communities in Canada. Back to the background of kidney transplantation, patients with end-stage kidney disease, they need dialysis or transplantation to survive. And kidney transplantation provides longer life expectancy, improves quality of life, and is less expensive compared with dialysis. Living donor kidney transplantation is associated with shorter waiting times and longer graft and patient survival compared to deceased donor kidney transplantation. And therefore, from a medical and societal perspective, living donor kidney transplantation is the treatment of choice for many patients with end-stage kidney disease. However, patients from marginalized racial and ethnic groups face disparity in access to living donor kidney transplantation. For example, with respect to Indigenous peoples, compared to non-Indigenous peoples, the Indigenous populations in Canada have 3 times the incidence and prevalence of end-stage kidney disease. They have a higher prevalence of severe chronic kidney disease, increased incidence of earlier onset CKD, of having diabetes as a comorbid condition or cause of CKD. They have a greater travel burden to receive care. However, despite all of this, Indigenous peoples were less likely to receive kidney transplantation, while Indigenous peoples, for example, in Saskatchewan, represent 16% of the population. In Canada, they comprise 50% of the patients on dialysis and only 15% of those who receive kidney transplantation. And there were similar disparities that were described in other provinces in Canada. Indigenous patients may experience greater delays in the pre-kidney transplant workup and are less likely to be placed on the wait list. They're more likely to wait longer for kidney transplantation. And there are a number of barriers that were identified for Indigenous people. First of all, several studies have shown, and this is an example here from the Indigenous peoples in Alberta, that their willingness to donate was lower than the general public. But further to that, there were knowledge gaps with respect to donation identified in focus groups in Manitoba and Saskatchewan, highlighting the need for education, and especially regarding donor eligibility and what happens to removed organs, etc. There were cultural barriers where different focus groups in Alberta and British Columbia with Indigenous communities there found that some participants shared a community belief that it's important to enter the spiritual world with an intact body, and that such beliefs may hamper interest in organ donation. Family and community are key influences in decision-making, re-organ donation, and need to be consulted. And lack of trust in the healthcare system is an important barrier to donation. There are also systemic inequities and logistical barriers due to the social determinants of health, for example, poverty, access to care, geographic distance. And these are also extremely important when you consider willingness to donate and access to organ transplantation with this population. With respect to East Asian peoples and the disparity in access to kidney donation, East Asian Canadians were much less likely than white peoples to receive kidney transplantation, to receive living donor kidney transplantation, to be referred for or receive preemptive kidney transplantation. And Chinese Canadians were less likely than the general public to register or provide consent for organ donation. And particularly, East Asian immigrants were the least likely, though living donation to family or close friends was considered more acceptable. Again, knowledge gaps were identified in focus groups with this community. There were also cultural barriers influencing beliefs, including Confucius values of caring for the body out of respect for elders and ancestors, and the virtue also of filial piety, which discusses the importance of maintaining an intact body after death and the impact donation may have on reincarnation. Death is also seen as taboo in Chinese culture, and therefore it can be difficult to discuss deceased organ donation. Alternatively, the authors noted that there had been descriptions of the values of generosity in Chinese culture, and that there was a view that organ donation is an act of kindness, and that is in favor of donation in that community. There can be mistrust, fears, concerns, and a lack of understanding of the donation process, and these can all act as potential deterrents to both living and deceased donation. Moving on to discussions of South Asian peoples and the disparity they face with kidney donation. Again, they're less likely as a population to receive kidney transplantation, to receive living donor kidney transplantation. In Toronto, a study showed that South Asian patients were less likely to have a donor at the first kidney transplant assessment, that not among non-Muslim participants. In one study, South Asians were much less likely to have a living donor offer. They're less likely to be referred for or to receive preemptive kidney transplantation. Again, knowledge gaps have been noted in some qualitative studies. There can be religious beliefs that can be facilitators or barriers to donation in these communities and populations. And as an example, in the Sikh and Hindu communities, there's a value of selfless giving and sharing, which can be in favor or supportive of organ donation. But on the other hand, in Islamic rulings in certain religious communities, there can be a lack of clarity on organ donation, and that can lead to some hesitance among Muslim participants. Family and community is also very important in the South Asian cultures, and living donation to family was supported by many focus group participants in the systematic review that was done. However, discussing organ donation, and particularly discussing deceased organ donation with family members, was viewed as challenging. In this community, it was noted that with respect to systemic factors, anecdotes and traumatic experience related to illegal organ trade practices abroad can create skepticism and worry about donation. It can foster general mistrust of healthcare and organ donation systems, regardless of the countries in which these practices occurred. I'll talk next about African, Caribbean, and Black peoples, which faced also disparity in access to kidney donation. And the disparities that these populations face in the United States with respect to kidney transplantation are well documented. In Canada, African, Caribbean, and Black patients with end-stage kidney disease were much less likely to receive living donor kidney transplantation, less likely to have a potential living donor at time of first pre-transplant assessment, less likely to receive an offer of donation from a living donor, and were less likely to be referred or to receive preemptive kidney transplantation as well, less likely to undergo donation as well. This community has been shown in several studies to have greater hesitance related to talking to others about the need for a living donor kidney transplantation, less likely or having a greater hesitance to ask someone directly to consider donation or to share educational materials on kidney transplantation with potential donors. And this was particularly true of immigrants from sub-Saharan Africa in one study, which showed lower rates of registration for organ donation versus the general public, and that their families were less likely to consent for organ donation compared to long-term residents. In focus groups with the Haitian community in Montreal, varying levels of knowledge about organ donation were found, and religion and spirituality was found to impact donation beliefs in that community, where some participants preferred to, quote, go to God whole, whereas others would be willing to donate if it did not interfere with them going to heaven. In those same focus groups in Montreal with the Haitian community, there was a perspective shared that organ donation is viewed as primarily benefiting white people, and that alludes to potential systemic mistrust and a lack of understanding of the need for donation in the Haitian Canadian community. And related, expanding on the systemic factors of that mistrust, there's a fear of being misjudged, a fear of the healthcare system and lack of representation, and all this negatively impacts access to kidney transplantation in these communities. Participants shared fears that they would be, quote, taken advantage of. There was a concern that the physician may be more interested in saving organs than saving the donor's lives. And there were solutions shared by focus group participants that having Haitian community leaders and healthcare professionals leading education efforts can lead to greater trust than with efforts that were led from, quote unquote, an outside community. And I'll share with you a quotation from an African Caribbean Black community member who was participating in the ACB Organ Health Initiative. Quote, "We don't understand and we don't believe that the system is for our best interest. So there is that degree of suspicion, and the suspicion could result in us not revealing information that could be valuable, and also at times giving misinformation because we're not understanding what's happening." The systemic racism in healthcare does compound lack of trust. And an example in the kidney transplantation field specifically is inequity in race-based adjustments of GFR, or glomerular filtration rate calculations, and subsequent differential access to donation. So the GFR is used as a cutoff or a threshold by nephrologists to determine when to list a patient for kidney transplantation. And many centers have adjusted or use adjusted GFR cutoffs for race based on the outdated assumption that Black peoples have a higher muscle mass and therefore higher baseline GFR, and therefore should have a different GFR cutoff than people of other racial groups to list them as kidney ready for a kidney transplantation. But this ultimately represents a barrier to Black people being listed as donors and compounds existing disparities in a population that's already disproportionately lacking access to kidney transplantation. It also engenders mistrust of the healthcare system. And these are examples of news stories that have recently reported on this phenomenon. So in terms of solutions globally, solutions to address disparities in all these donor pools, blood, stem cells, organs, and tissues, it's important to address the specific barriers to donation for a population. And so, for example, for Black peoples, as is the case with other specific ethnic populations as well, there is a mistrust of the healthcare system that needs to be addressed. And this is a quotation from a focus group participant of the Stem Cell Club Black Donor Save Lives campaign. And this participant shares, quote, "Even though I know it's a great thing, I know that a lot of Black people have a good reason for not doing it, for not donating. The way that a lot of us are viewed in the medical community, I completely understand why some people would be scared of donating and not want to put themselves in that situation. Generating a starting point for solutions, it's important that healthcare teams develop and implement donation policies that prioritize equity alongside patient safety and quality and address systemic racism in healthcare. For example, with respect to HIV-2 risk, find ways to avoid barring people from African countries from donating blood. And that is what was achieved by Canadian Blood Services in recent years. And similarly, with respect to GFR cutoffs for kidney transplantation, centers need to stop using those cutoffs, which disproportionately disadvantage groups that are already not accessing kidney transplantation at the rates that are needed for those communities and populations. Furthermore, donation messaging needs to from healthcare providers and members of the particular community of interest, not from an outside group. And this work needs to proceed alongside broader efforts to address systemic racism in healthcare and mend bridges between populations that have historically been mistreated or disadvantaged by healthcare systems. With respect to East Asian peoples, and I'll focus on one particular barrier that can be addressed, filial piety, which states that each and every body is unique, a gift from one's parents and something that should be cherished and respected. This is a quotation I'll share from a stem cell recipient, Hyung Up, who shared his story on Why We Swab, which is a story platform that shares stories in stem cell donation. You can read the full story at the Instagram link below. But the Hyung Up shares, in my culture, the idea of donation still scares many people. In Korean culture, for example, there's an old saying that goes, do not disrespect the body that your parents created for you. So for a while in Korean history, people didn't cut their hair. Though times have changed significantly from then, the sentiment still exists to a certain extent amongst some of the older people of older generations. With respect to solutions for this barrier, it's important, again, that donation messaging come from members of the community, in particular, elders and leaders of the community. And it's also important that educational materials be translated into different languages spoken by those peoples so that they can be reached by messaging. As well, there can be lack of knowledge and the need to raise awareness through culturally sensitive and tailored recruitment campaigns led by members of those communities about the need for diverse donors. So with respect to blood donation, I share on the left a campaign from the Red Cross in the United States, highlighting sickle cell disease and the impact on Black patients and the need for Black donors. And on the right, similar efforts are being led by Dr. Jenny Ha and Viva Tinga in collaboration with the Sickle Cell Disease Association of Canada and the Sickle Cell Foundation of Alberta. With respect to stem cell donor recruitment, I share with you here 3 campaigns that Stem Cell Club has led and developed by 3 of my trainees from the respective communities. So on the left, you can see Black Donors Save Lives, which is led by Sylvia Akranafwab, and in the middle, East Asian Save Lives, led by Lauren Seno, and on the right, South Asian Save Lives, led by Rupal Hatkar. And you'll hear more about each of these campaigns at the Trainee Donor Research Network Symposium next month. And in summary, though, in brief, each of these campaigns put together an array of high-quality recruited multimedia developed by and for members of that particular community group population to educate about stem cell donation. And in particular, we evaluated our Black Donor Save Lives campaign and surveys and focus groups with 39 participants, all members of the African, Caribbean, and Black communities of Canada, recruited online. You can see that there was a young cohort, about 45% male from different locations in Canada. And you can see that before versus after viewing an array of multimedia resources of the campaign, viewing the multimedia significantly improved their knowledge and improved their attitudes towards donation. and as well addressed barriers to donation, where the majority felt that the multimedia helped make them more supportive of donation, reducing barriers to donation. And qualitative analysis of feedback from focus groups identified specific examples of how that multimedia decreased barriers to donation for these communities. And you can see the example I'll list here with respect to mistrust of the healthcare system. Quote, after looking at this multimedia and seeing how simple the procedure is on our end and seeing how much it affects our own people, I think educating more Black people on this simple thing that we could all do to help a lot of people just like us, I think that would help a lot. Yeah, I want to highlight the ACB Organ Health Initiative, a collaborative effort and initiative where people from the ACB community in Canada are coming together to raise awareness about organ donation and share stories of organ donors and recipients. I'll conclude my talk with 10 tips for building recruitment campaigns to engage specific demographic groups as donors. And these are tips that we developed or deployed with our recruitment campaigns with Stem Cell Club. First, it's select a group of needed donors to engage, and then build a network of individuals and organizations from that population, from that community with whom to collaborate. Identify barriers facing that particular demographic group to register and donate through literature review, through discussions, etc., and collaborate with members of that group to develop engaging multimedia to educate about donation and address barriers to donation. Invite members of that demographic group to review and approve the materials and the overall campaign plan, and then run the campaign during a period of significance for that demographic. Secure partners, national, regional, local, grassroots, to disseminate the resources to their networks, and engage media to the campaign as well, that is, develop and share compelling press releases. Evaluate the impact of the campaign, and then improve based on feedback and repeat it. Thank you all for listening to this talk. I want to acknowledge all my collaborators listed on this slide, as well as funding from the Canadian Blood Services Blood Tech Net Award. And thank you also to the Donor Research Network organizers for inviting me to give this talk. Thank you.